Good afternoon, everybody, and welcome to Grand Rounds today. Before we get started, I just wanted to mention that the CME committee is always looking for suggestions in regards to future topics and future speakers. So if you're joining us remotely, if you can just put in the chat box if there's a topic that you'd like us to address or a speaker that you've heard that you think would be interesting for us to ask to present here. We'd appreciate that. And if you're watching this in an archived format, if you can put it in the comments box, we will certainly look at that. So appreciate the ideas. Today, it's my pleasure to introduce Dr. David Cain. Dr. Cain received his degree in podiatric medicine from Des Moines University and then did his residency at Columbia St. Mary's in Milwaukee. He's been a member of the medical staff here at MGMC since 2019, and he kindly has accepted our invitation today to present on total ankle replacements. And please join me in welcoming Dr. Cain.
So, thank you. Yes, I'm Dr. Cain. I'm one of the podiatrists or foot and ankle surgeons here at McFarland and Mary Greeley. And I have no financial disclosures for this presentation. Quick little background about me. I went to Central College in Pella, Iowa. I played varsity football there, and my freshman year I broke my ankle. So a lot of people ask, is this kind of how you got your start in your field? And I say possibly. I grew up on a farm, and so the initial plan, I guess, was to go back and do that with Dad, and he told me I had to get a real job. So the only other thing I had a big interest in was biology in school, and so I got my Bachelor of Arts in Biology, and talking with my advisor there at Central, they had a new program, a master's degree in anatomy at Des Moines University. And I did fairly well in those courses in undergrad, so I thought I would try that at DMU. And one of the nice things about that is I had to take all the same classes that the other physicians were taking, and then I taught in the anatomy lab. So effectively, I was doing surgery almost every day and really enjoyed that. And so I got to talking to some different physicians, and one of them was a doctorate of podiatric medicine, so foot and ankle. And there you do 4 years of school, just like anybody else, again, taking a lot of the same classes as our other colleagues do. But we focus more on the lower extremity, and then your residency is 3 years of nothing but foot and ankle. So fairly specialized right out of the gate. And so I did that. And then I went to Columbia St. Mary's in Milwaukee, where, again, did 3 years of foot and ankle surgery. Again, I'm from a family farm in Winterset, Iowa, so that's kind of south central if you're not familiar with the Iowa area here. And then I've been here at McFarland for about 3 years. I currently offer services in Ames, Iowa Falls, and I do work in the Wound Healing Center over at Mary Greeley. And I guess I'm proud to say I'm the first and currently only provider to offer this service to our surrounding community. So what sets us apart? I get this question a lot as to, what it is that you do. I have some patients that'll come in and say, oh, my grandmother sees a podiatrist. And we certainly do things like corns and calluses, but since early 2000, I guess we kind of have some new tricks up our sleeve, if you would. We do 3 years of extensive foot and ankle training. And again, that begins in medical school where we take a lot of the same classes as other physicians. And we take general anatomy, so head to toe anatomy, our first year. Our second year of school, we dive in for 6 months doing nothing but the lower extremities. So essentially from the hip down with a special focus from the knee down, really focusing on soft tissue, tendon, muscle attachments, that type of thing. We take multiple rounds of boards, which is kind of a hot topic with those in my profession at the moment. But the focus is more on the lower extremity anatomy as well as biomechanics, and then how do certain conditions such as diabetes or peripheral vascular disease, how do those patients present with lower extremity issues, or how does that affect our services if we're looking at, so today, something like a total ankle replacement. And then that continues on through our residency again with 3 years of training in surgery, so forefoot, midfoot, rear foot, and ankle reconstructions. So the services that we provide to the community, again, today we're talking about total ankle replacement, so I put that at the top. Trauma. I do a fair amount of trauma here from, the farmers who get hurt in the spring or the fall during harvest, athletes that hopefully don't have any injuries quite like this, but just to show you some of the extensiveness in something like a reconstruction. This individual here, both of these soccer players, if they didn't, well, the second one there definitely broke something because his ankle's facing the wrong direction. But the first one up there could require not only bone work, but also soft tissue reconstruction if he, tore a bunch of ligaments. So sports injuries are a big part of what we do. And again, that's kind of near and dear to my heart, being an old football player and having my own set of injuries. And then recently, I became board certified in sports medicine. So I'm kind of excited to pursue that pathway as well. But again, we do things such as ingrown toenails. We'll probably start to see a lot more of those as the kids get back to school and start participating in sports. I work in the wound clinic, so I do a fair amount of wound care. And then we also do custom orthotic fabrication. So our biomechanics training on, how does the foot affect the knee, the hip? How does a hip, if you had a replacement, how does that affect the ankle or the foot itself? So they're all connected through the lower chain. So reasons for an ankle replacement, because that's what we're here for today, and hopefully no one has ever done this with a friend anyway, would be post-traumatic arthritis. That's the most common, and that's damage to the surrounding cartilage that causes it to thin and wear out over time. It could also come from malalignment. So if someone had a very serious fracture, which we'll show kind of later on, as good as we try and realign these bones, we can never get them to the way that you were born with them. And so that can start to cause early wear on certain parts of the ankle or the lower body. If you had a knee replacement or a hip replacement, perhaps a small amount of bone was taken out, perhaps too much bone was taken out or not enough, which can give you a limb length discrepancy. That can then cause problems down the chain, especially at the ankle or the foot, because we're trying to compensate. So again, everything is connected. Post-traumatic arthritis usually develops in a shorter time frame than the next category, which is osteoarthritis. And for lack of a better term, this is kind of the old adage of, well, this happens as we age. We wear things out over a longer period of time. And unfortunately, again, I have a patient that will show that they eventually kind of wore out their ankle and had some issues with that. So originally, the way that you treated ankle arthritis surgically was you would fuse the ankle. That was kind of the old, gold standard, if you will. Today, we have some pretty good data behind ankle replacement. So is this becoming kind of our new gold standard? I certainly think it's the way that we're moving. I'm a big fan of trying to save motion versus fusion. If we fuse a joint, the surrounding joints have to compensate. And so that can lead to early arthritis in other parts of the foot or lead to early breakdown. The worst thing, it's called a pan-talar, but you essentially fuse the ankle and essentially the entire hind foot. Patients are usually very miserable with this type of fusion. And so we have some pretty good early data in studies showing that if we can do an ankle replacement, we spare these other joints, and these patients may never need a fusion in other places of the foot, which is pretty exciting, at least from my standpoint, that we can maintain motion and try and keep these patients comfortable doing their daily activity. So the history behind this, the first total ankle was done in 1973, and they used hip components. And you can probably guess this probably didn't work out too well. And initially it had a terrible failure rate, around 50%. And it really brought to mind for individuals to really appreciate the structure and complexity that the ankle provides. And so companies started pouring money into research and development to solely study and focus more on replacement parts for the ankle. Our first generation parts came around in 1980. The second generation began around 2000. And then some of the parts today, depending on what company or implant you may use, are in their third or fourth generation. And so the history continued here. The agility, its claim to fame was it was developed in Iowa, and I won't say where, but it wasn't Ames. If you individuals who do these procedures quite a bit, this is probably the most common one we're running across that was from the 1980s or early adoption of total ankle replacements. There were some issues with this, and so a lot of them are having to be replaced today. And then you have mobility, buccal pappus, which I'm probably mispronouncing that. I have never run across one of these implants. The Exactech Vantage, the Salto Talaris, the Star, which is probably one of the more common ones that we'll run across, and we'll kind of dig into that one in a minute, the Inbone, and the Infinity. And I guess personally, these last two, the Inbone and the Infinity, are my preference, and we can kind of go into we can get into why here as we go. Early lessons, though, learned is we wanted to avoid large bone resection, and that's so we don't decrease bone integrity or the density. Decreased bone density or loss of integrity can lead to implant failure and need for revisions, which can lead to other complications. So these were initially approved for cement. We have since determined that it's better if you don't use cement unless it's a big revision case. So they're more of a press fit today because the cement can lead to osteolysis, which leads to loosening and again, need for revision or implant failure. Biggest takeaway is respect the medial and lateral collateral ligaments. These ligaments are essential to maintaining ankle strength and stability. My physical therapy individuals here today probably have a really good understanding of that. So they help maintain the ankle joint and they help maintain the implant in place. And that was the big issue with the agility implant, is that it put those ligaments at risk and led to a lot of failures down the road. So again, the types of implants we have, there's two flavors. There's a mobile bearing and there's a fixed bearing. And the mobile bearing does that show up? Yeah. So my mouse up here at the top, this is the Star implant. Today, it's the most commonly used mobile bearing. Mobile bearings allow for more flexibility and decrease in shear force. So there's less compression on the tibial side of the implant. However, they can lead to better or greater impingement. Because of that flexibility, you get the soft tissues impinging into the joint. And they can also have increased subluxation because this piece, it's called the poly. It's essentially a glorified plastic component. It can slide out of place or sublux. That led to the second flavor of fixed bearing, which decreased subluxation because all the components are tied together, and decreased impingement, again, because we sacrifice flexibility. The slide before talked about loosening or increase in shear force, and that's why this one, the Inbone, was developed. This stem goes up into the tibia, and the design behind it is that it offloads or decreases shear force at that interface. This shows a 3-stem component. As far as I know, you can go wild and do as many stems as you would like. You could stem to the knee. Not that I would recommend ever doing that, but it is a possibility. And then lastly, again, this is the Infinity. So just so you can see the difference between the Inbone fixed bearing and the Infinity fixed bearing. And again, these are the two that I use most. So again, most of the implants you're going to run across, if you have the opportunity to see one, are going to be fixed bearing, except for the Star, again over here, and then the Exactech Vantage has a mobile bearing. I didn't bring it in because currently they have a class action lawsuit against them, so I'm not sure if that implant will stay on the market or how much longer it will be. The Star had an FDA warning out approximately 2 years ago for packaging around the poly that could lead to increased breakdown and need for revisions. The company has since gone back and repackaged them with a different proprietary material to try and maintain protection around that implant. So these are just some of the things that if we're going about trying to pick an implant or select an implant that we have to consider. To get into some studies, Godot had a study, it was from 2014, but at that time they demonstrated that fixed bearings were equivalent, if not better than mobile bearing implants, again, to decrease subluxation and decreased impingement. And then Coetzee, as of last year, demonstrated that mobile bearings had 3 times higher revision rate than a fixed bearing. The downside to that study is he looked at one type of implant, the Salto, which is this guy down here, and the Salto Talaris. The Salto itself is not available for use in the United States. So, in regards to just looking at mobile versus fixed bearing, I think that study can be, extrapolated across for the different types of implants that we do utilize. So again, the implants, the STAR. So this one, the STAR has probably the longest or the best long-term data out there. Coughlin study demonstrated that it had 90% survivability at 10 years. Clo had a study, again, looked at long-term results, so 5 years, 10 years, 15. At 5 years, you had 90% survivability. At 10 years, you had 82.7. And at 15 years, you had 76.1% survivability. The average age of their study group was 54, and these implants were put in between 1993 and 2000. And if you remember from an earlier slide, these were either first-generation implants or early second-generation. And so the STAR and the InBone Infinity are on later generations. So the hope or the thought is, and there is early data behind that, that the survivability rates of these implants is getting better because we're continuing to learn more. The InBone, again, this one up here in the top right corner, the increase in stems, increased contact at the tibia to decrease shear force and as well as stability. It's a good option if you're doing a revision. Say a patient has a STAR, a mobile bearing that fails. The InBone is a good one that you can try and salvage that ankle with. The next one down here is the Infinity. It requires less bone resection, so we do use it in generally younger patients. The trade-off depends on the deformity. And I can show this in just a little bit. The less deformity that we have, the less manipulation and shifting we have to do. Some of you may have seen it earlier. I have this wonderful little jig down here, and I guess little is a little bit of sarcasm, but we can really correct a great amount of deformity with this jig. But then we usually have to use a larger implant. Again, quicker. Is it always better? So with the Infinity, now we have the ability to take CT scans and create 3D custom components. I'll try and hold up one here, but essentially this is the CT scan of a patient's talus. And then what they do, so this is the talus part or the top half. And then what they do is we can print out the cutting jig and they have a nice fit to them. And we have that implant in the operating room where we can pin it into place and now we can cut right off of that. So I have a model that's an exact replication of the patient's ankle. And then again, we can replicate that on the patient themselves with custom implants. And then the Envision is the last one here. This is the only FDA-approved implant for revision. The parts are interchangeable between the InBone, the Infinity, and the Envision because they're all created by the same company, which is nice, so that you don't necessarily have to rip everything out and start all over. It does use a much thicker poly, as you can see right here through the middle, and that's to try and restore height if we have to resect a lot of bone. But again, the trade-off there is we have to respect the medial and lateral collateral ligaments and probably reconstruct those if we're using a thicker poly because we're putting a lot of strain on the ankle itself. So these are just some of the things that I go through if I'm looking at a patient who may be a candidate for a total ankle. They are constantly evolving. And if you asked me versus, say, someone in Des Moines or someone on the East Coast versus the West Coast, we're going to sit around and probably have a good little debate as to, what really matters or what's important. So, but just a few things would be age, BMI, comorbidities, their activity level or their occupation, which I think is a fairly, or is a big one to really consider. The contralateral limb, which we're learning more and more about, because that other limb is going to be their sole way of propulsion for several weeks. And if they have fusions or replacements over there, we have to make sure that those are going to be stable. Does the patient have some type of other foot deformity, or is there another issue such as arthritis, again, an implant, or just the structure? Do they have what we call pes cavus, a very high arch, versus pes planus, which is a very low arch or flat foot? And then which implant to utilize? Do you use a mobile bearing? Do you use a fixed bearing? And then lastly, home hazards. So does the patient have to get up steps? Are they going up 2 steps into their house, or do they have 3 flights of stairs up into their apartment? Do they have rugs on the floor? Do they have grips in the shower? How are they going to be able to get around if this procedure is performed, and would they be safe at home? So to dive into some of those, personally for me at the moment, generally prefer a patient who is over the age of 55 and less than 80. Now, there are exceptions to every rule. I do know individuals much younger that have totals. I know a couple individuals who are older than 80. And again, this all goes back to, what are the comorbidities of the patient? What is their expectation? What is their activity level? How is their, do they have osteoporosis, osteopenia? Those types of things all come into play. Currently, there is a study in the United Kingdom where they are looking at patients as young as 45 and how they are doing. They have early good outcomes is what they say, but the younger the patient is, the greater the chance for revision, because of course a younger patient is going to be a lot more active. If you're more active, you're going to have more wear on the implant. Again, at 15 years, if it's 76%, but I'm putting it in a 45-year-old, the chances of that implant lasting 15 years are probably much less. And again, a 45-year-old probably still has 15 years or so in the workforce, which again is going to increase stress on the implant. BMI, this is the one that gets kicked around a lot. Some patient or physicians will say, BMI of 40 is a cutoff. Others will say, well, if that patient is 6'5" and has a BMI of 40, that's a lot different than the patient who's 5'1" with a BMI of 40. So again, Barg and his colleagues found 93% success rate at 6 years with implants, and the average BMI was 33. Now, again, you'd have to go back in and dig into, okay, what's the average weight? Because if, again, you're 6'4" or 5'1", a 33 BMI is a huge difference. But the big thing out of their study was they found no trend in obesity for loosening, which is great. And the patients actually had a decrease in their BMI 2 years after getting the implant because they were more active. So, and I'm sure a lot of physicians hear that adage a lot. Well, I want to be more active. I'd like to lose weight, but I have this pain or this limitation, so I can't do what I want to do. So the other indications or considerations include diabetes as well as their A1C. There is evidence behind greater than 7.5 A1C that you have delayed healing, which is a problem for the implant that I use. It does require a fairly large incision down the front of the ankle. There are a lot of nerves, neurovascular bundle, and tendons on the front of the ankle that we do not want exposure to. Greater than 7 A1C has shown increased infection rates and possible failures. Lifestyle and occupation, again, this is the big one, I think, for me. I see quite a few patients where we're either at a desk job or on the factory floor. So at 3M, at Danfoss, at Pella Windows. Those patients, they could be the same age, have the same body type, same BMI, but that patient on the factory floor is going to have a lot more abuse of their implant than someone who is performing a desk job or has limited ambulation needs during the day. So, the patient who walks, plays golf, they swim, or they ride a bike is going to be a lot better patient than the individual who is a rock climber, skydiver, or a bodybuilder. Again, just because of the sheer stress on the implant. And then lastly, do you need to do staged procedures? I do have some patients coming up later this fall where they had other foot issues going on that had to be addressed before we could do the implant. Because if those deformities or issues in the foot are unaddressed, it will lead to early failure of the implant. And again, that's the last thing we want. So, and then the other ankle. Is the other ankle fused? Is it short? Does it have implants? And we touched on this a little bit earlier. So do they have a knee replacement or a hip replacement where the leg is a little bit shorter or a little bit longer? So the opposite foot, the one we're going to work on, is trying to compensate. And so we're trying to adjust for that individual. So contraindications, and again, big debate in here, would be very young, very active. Again, there are some studies going on in the United Kingdom where they're looking at younger and more active patients and how some of them do with an implant. Severe lower limb malalignment would be a contraindication. If that implant has to try and accommodate for too much shortening, or say they had a really bad tibial deformity, the implant would not sit basically in the mechanical or the anatomic access, and that can lead to catastrophic failure. Significant osteoporosis. This is something I work up patients for a lot before we do any type of procedure metabolically to ensure that they have good bone density. Otherwise, the implant will essentially kind of crush through their bone. We do have some tricks to try and help with osteopenic or lower bone densities. One of them is a flat cut talus. And that essentially is just what it means. When we put this implant in, and I'll show it in our x-rays here in a minute, we cut the talus straight across. And I put these numbers in here just to show you the huge discrepancy between the surface area of a hip, a knee, and then your ankle. So it's very important that we get this implant seated correctly. The ankle is not nearly as forgiving as a hip or a knee because of the total surface area. And if we don't get this pressure distributed evenly, again, it can lead to early wear on one side of the talus versus the other. And we don't have a lot of room to work with in the ankle. So avascular necrosis, or death of the bone, is a contraindication. I would tell you at a couple of conferences, there are some individuals on the West Coast who are still putting them into patients who have this. They use what are called rafting screws and cement. And so we're kind of waiting to see long-term outcomes on those types of individuals before we move away from something like that. A poor soft tissue envelope. Again, does the patient have a lot of peripheral vascular disease, so they get kind of that brawny discoloration to the lower extremity, which can lead to poor healing, or, if you cut through that, it may not heal at all. Smoking. A lot of literature says this is a contraindication. I will just say this is an absolute contraindication for me. If you are smoking, I will not put this in. There is too much risk of the small vascular structures around the ankle to risk it being occluded by smoking. The soft tissue envelope can also be inhibited in its healing by smoking. And so for me, that's an absolute contraindication. And recently in 2021, there was a new study out that looked at depression, which I thought was very interesting. And individuals with depression were shown to have demonstrated negative impact on their recovery. So they took longer to heal. They had more wound issues. They required longer times of non-weight bearing or extended periods of time in physical therapy to get to kind of the end goal that we're all looking for. And so that was, I thought, an interesting new study to kind of follow up on. So absolute contraindications, again, mine, definitely smoking. Active infection, which again is pretty self-explanatory. Severe peripheral vascular disease. So if we're not able to palpate pulses, that patient needs to be worked up and see, do they have occlusion or stenosis that needs stented? Or if they're not amenable to that, then this is a patient that would not be amenable to a total ankle replacement, again, for healing purposes and bone integrity. Charcot, which I put in a quick picture of Charcot here on the bottom. That is a disease, Charcot neuropathy, where they have dislocation of multiple bones in the foot. The bones can fuse into malaligned position. These patients often have complete neuropathy and no feeling, and they may present to your clinic with what we call a rocker bottom deformity. These patients cannot have an implant, because if the implant fails, again, if they're walking on a foot like this x-ray, they would never know if that implant failed, and that could, again, be catastrophic. And then peripheral neuropathy. So again, if you have no feeling in your lower extremity, it's right now, that is kind of the number one absolute contraindication to a total ankle. So the approach, I get a foot x-ray, an ankle x-ray, something called a hindfoot alignment. So I can look at essentially how does the foot relate to the lower extremity and determine, does this need to be a staged procedure, or are there other procedures that are needed? And then a CT. And we use that CT, again, to see, is the patient amenable to custom implants? And, afterwards, if you want, I've got several different types of custom implants here. So these are CT scans that were then 3D printed into the patient's bone structure. So this is the tibia. And then again, off of that, what we can do is we make the cutting guide or the jig. And again, in the operation, we can sit there and make sure that that press fit goes to where it needs to be. So we have a model on the back table, and then we have the implant itself. So again, we can extrapolate that from a 3D printed model to the patient themselves. And again, oftentimes it leads to quicker surgeries because we have less dissection. We know once the implant is in place, we can kind of move forward from there. But again, I've got a couple of tibial pieces, and this would be the tailor piece again with its respective kind of cutting guide or press fit that goes right on top. So these are nice little adjuncts to have. Not all patients are able to use that because of perhaps the deformity that they have. And so I'm going to grab this thing real quick and I'll see if I can hold it up. So that's where this big guy comes in. Oop. So this is our jig, and this allows me to correct the ankle and the foot in all three planes. It has a whole bunch of knobs that we're able to manipulate, and so we can rotate it, we can translate it, we can move it up and down. And we do this under live fluoroscopy in the operating room. And the heel sits basically in this cup at the top, and then it has a calf support. And then utilizing, again, intraoperative x-ray, we kind of manipulate the frame and the foot into the correct position that we need to get the adjustment or the positioning. And then we can move from there. The biggest thing with this is I often have to make an incision in the heel, and we drill basically from the bottom of the foot up. With the CT guided implants, we have removed that step and we can go right into the ankle joint itself and cut from there without having to come through the bottom of the heel. So at the moment, most of the patients that I've done total ankle implants on, unfortunately, have enough deformity where I have to play with this big jig. So like this gentleman here. So this gentleman had the first total ankle replacement here at Mary Greeley. When he presented to my office, he was a 70-year-old male with a history of diabetes that was diet controlled. I believe his A1C was 6.1, and he did not have neuropathy. He does have a history of COPD, and he had bilateral knee replacements, but he did not have a limb length discrepancy. He fell off a ladder in 2009 and sustained a pylon fracture, which is why this hardware is currently in there to reapproximate all the broken bones that he had. And he presented to my office in 2020 with complaints of continued pain. It affected his activities of daily living, and he was not able to really move his ankle at all. And you can kind of see that in his x-ray down here. He kind of has a spur off the back of the talus and a little bit of the front, which again, severely limited his range of motion. And he was in the VFW honor guard, and so he did a lot of that during the spring and summer. And he just stated essentially that he had a lot of complaints and was miserable trying to, do these duties. The CT that we got is a nice adage because right here, you can see that he has a large cyst in his talus. And certain cuts through the talus would not have removed this cyst completely. And so we would have a defect with the implant on top, which I believe personally could spell disaster. The nice thing about the flat cut talus is if you look, we go right off the neck and we're going to cut that entire cyst out. So we took him to the operating room. We removed his hardware, almost. This one broke and I was not able to retrieve that one. And we put in a total ankle replacement with several stems. And again, you can see this is our flat cut talus. And so we removed that entire cyst. This individual, because it was the first one done at Mary Greeley, they put him on the Health Connect. And so today he's currently 18 months post-op. He is doing wonderful. He serves in the VFW Honor Guard now, still, rides his Harley, and he's able to dance with his wife, which she states he was not able to do for years because of pain in his ankle. This young lady is 68-year-old female with a history of IBS and osteoporosis. We sent her back to her primary care physician to work up the osteoporosis and get her on either vitamin D supplementation orally or injections. I usually leave that to the preference of the provider. It also depends on how bad the osteoporosis is, which usually involves a DEXA scan. But once she had been optimized for surgery, we had several months of discussions with her. She had been receiving ankle injections for 4 to 6 months routinely since 2008 from an orthopedic physician. And when she presented to my office, she said, well, she was told that no one should ever have a total ankle replacement, which is unfortunate. But between myself and her primary care physician, we were able to go over all the risks and benefits for the patient and get her medically optimized. And then in late 2021, we did the Infinity total ankle replacement. So again, less bone resection, goes off the custom 3D printed parts. And she's doing very well now. She is back to doing her daily activities without much limitation or restriction. And it's always nice to hear, but her biggest, not complaint, but her biggest statement was she wished she had done this sooner. So that's always wonderful to hear that patients do well with these implants. We will continue to follow her each year with an x-ray to ensure that there is no failure or any issues that occur. Biggest thing with these implants is they can get heterotopic ossification or extra bone formation, which can lead to impingement sometimes. So in a few years, it may need to have some bone removed, or again, if the implant or the poly in between wears thin because she is very active, it may need to be replaced. Hopefully not for 10 to 15 years. So the last individual I put on here because we did bilateral ankle replacements on him. So not at the same time, of course, but he was a 71-year-old male, history of hypothyroid, AFib, heart murmur, and vitamin D deficiency. So again, all of these were addressed prior to any surgery. He had been receiving stem cell injections in Arizona, and he was a recent transplant to Iowa due to family being close. And he stated when he came in that he didn't know that this was even an option. And so he was ecstatic, but he also didn't want to undergo any surgery just yet. And so we started with what's called an AFO, or ankle foot orthosis. It's kind of a hard leather brace that starts just behind the toes and goes above the ankle. So it's to mimic a fusion, essentially. And so we tried to stabilize him that way. Initially, when he came in, he stated that his left hurt worse than his right, but further imaging demonstrated his right had a significant peroneal tendon tear. And so these are some of his x-rays, and you can see, we have loss of joint space here. We have a little bit of posterior displacement of the talus. Otherwise, he could get along during the day, but he would have pain towards the end of the day, and as well as swelling that gave him trouble. So we ended up doing the right foot first. We did the peroneal tendon repair, and we were going to do the left ankle a couple months later. But because we fixed the peroneal tendon, he became more active on the right, and he stated that it was killing him. And so we decided that we would fix the right first, and we would try and brace the left to try and buy him some time. And as you can see, we put again, it's called the in bone, into the right ankle here with a flat cut talus. And if you caught it, again, we're on a different generation of implant. If you look at the talar component here, it has 3 little stems to try and decrease the amount of bone taken. And if I go back here, our individual from earlier had an earlier generation stem that's a little bit larger. And so again, these implants are still evolving to try and reduce the amount of bone resection that's required, which is nice. So again, here's his hind foot alignment film just to show that we did the implant on the right, and we have no major deformity in his hind foot, nor do we have it over here on his left foot. Excuse me. Generally, I try and wait about a year if we have to do bilateral implants on a patient, just to make sure that everything is stable and is healed well. He came in, we had tried injections, we had tried bracing, and he just said he couldn't do it. And so he goes, how soon can we do it? So I told him we would look at 9 months. And 9 months, ironically, was August 1st. My surgery day was August 2nd, so we did it on August 2nd. Currently, on the right, he's 10 months out. And on the left, I saw him recently. He's 2 weeks out from the left one. And the left one is doing well. We'll kind of see here in a couple weeks. He'll be headed to the pool and hopefully get him moving, and he'll do just as well with the left as he did with the right. So, and again, this is just images of his left. You can see a lot more bone-on-bone contact, severe degeneration of what we call the tibio-talar joint. And so the left one was worse, but we had to go right and then left. So my post-op protocol, I generally do no weight bearing for 3 to 4 weeks. I get them in the pool, or we do have the benefit of having something called an Alter-G, which is like a suspended treadmill. So we can adjust the amount of body weight that they're putting through their lower extremity. And that starts around, again, 3 to 4 weeks. And then full weight bearing in a boot, or graduated weight bearing in a boot, is from 4 to 6 weeks. And we kind of have developed an extensive program with physical therapy on how to manage patients, or move them along through their recovery phase. And the patients, I believe, have done very well. And a lot of them seem to really enjoy getting in the pool because they can get moving sooner. So in conclusion, individuals who have arthritis can undergo either a total ankle replacement or an ankle fusion. Again, I'm a big believer in saving motion. There have been a large increase in the number of patients who are undergoing total ankles, and we have pretty good long-term results thus far. However, we still need to continue with that. Past studies and studies that are currently underway have demonstrated that a total ankle requires less compensation through the other joints of the foot, because we are salvaging the ankle, which is the main player for range of motion. This could spare arthritis elsewhere from forming in the foot, or, interestingly enough, they have not come out with the studies yet, but other individuals who have, say, arthritis in their subtalar joint, which is just below the ankle, or the talar navicular joint, which is the main mover of the foot away from the ankle, if they have arthritis to the point where a patient may require a fusion there, if they also have arthritis in the ankle and you replace the ankle, midterm results are showing that you don't have to address these joints, because the increased range of motion at the ankle is protective of the other joints in the foot. We've had significant advances. Again, they continue to evolve, which is fun, I guess, for me, because I'm early in my career, so I get to see the evolution of these implants as well. The designs and components are getting better, again, with the ability to now 3D print parts. There has been talk, I don't know how long it would occur, but the ability to have a 3D printer in the operating room that prints the part right there for you, which is kind of an interesting concept. We still need to have careful patient selection, knowledge of the implants. Even though I've never seen some of these older implants, I still need to know what they are and how they could affect the lower extremity, so that we can select the correct implant to replace them with. Excuse me. And then thorough post-op protocols. I know every patient is different, but for the time being, with this newer technology and newer procedure, I kind of try and keep patients on a certain schedule, even though some may be further ahead or some may be behind others. And we can kind of tailor that accordingly with the results that physical therapy is seeing as well. And then, again, it's an excellent option for those who have end-stage ankle arthritis, but we have to continue with long-term follow-up. So if you need to reach me, I'm in the foot and ankle or podiatry department. That is our phone number. This is my email at McFarland. If you have other questions, or if you have a patient that maybe would like a brochure. I apologize I didn't bring some with me, but I do have some literature if you would like to have some of that sent to your office for patients. Referrals are appreciated. If there are patients watching at home, my department is kind of nice or special in the way that we don't have to have a referral. Certainly, if you want to ask your provider about it, that is fantastic, but you can also call our office and schedule. The first hyperlink here is the article for that first individual who had a total ankle replacement. And then the second hyperlink is a YouTube video where they interviewed him. So if patients are interested in getting a little more information that way, they certainly can. So with that, thank you. And are there any questions?
How long is the hospitalization, or do they get to go home the same day?
At the moment, thank you. Medicare, if the patient is Medicare, it does require a one-night stay. Now, with COVID, there has been some discussion about even patients with hips or knees going home kind of the same day. I don't know that that has spread out to the ankle replacement, but right now, Medicare patients require a one-night stay. If you are not Medicare, as far as I know, it does not require an overnight stay. I have all my patients receive a popliteal block, so basically all the nerves from the toes come up behind the knee as one bigger nerve, and anesthesia puts a block on there that hopefully lasts 18 to 24 hours. And so I try and send all those patients home that same day.
Thank you very much.
Yeah, thank you guys.